Okay.
All right, we're back again. We're again having a few technical glitches, but this is another broadcast. So I would let's go ahead and we'll record this and post it. And so we were just talking about what the best way is for a patient to bring up issues or concerns that they have with sexual health.
So the first way, and I think the best way, is to rehearse a little, and then when you get in the office with your practitioner, to ask directly. And don't sugarcoat it, don't beat around the bush, just ask directly. But I fully recognize that that may not be so easy to do. And so one way to get around the directness, but to still get the question out, is to say something like, some of my girlfriends or some of my colleagues or some of my relatives, whatever you want to say, have told me that X, Y, or Z is pretty common. And then just say, I may be having some of that. Dr. West, what do you think? So let me just play that once. Dr. West, some of my friends have told me that loss of sexual desire in women my age is pretty common. I think maybe I've got some of that. Can we talk about it?
Absolutely. Let's discuss it. It's a common issue, and it is a problem that arises for women, and it's important to try to understand that a little bit better.
And that's really all that it takes. Get the conversation started. If Dr. West or someone else hasn't planned for that, or there's not enough time in the schedule for that, it's very important that the conversation goes something like, we really haven't planned for that. It's a really important thing. Let's block out some time in the schedule where we both can focus on this as a particular issue, and we'll get to it.
So what do you look for when someone starts that conversation and says they have decreased sexual desire? How do we put some parameters around it and talk some more about it?
Yeah, so for me as a practitioner, I try and get a context. Did it start all of a sudden? Did it occur slowly over time? Is it related in some way to a couple's relationship? Try and get a handle on what's actually going on for her. If it just seems to be related to the length of their relationship, or the time they've been together, or aging just in and of itself, then we focus on those issues. The one thing that I think is highly relevant to all the listeners is that reduction in sexual desire can be hormonal, can be situational, can be a part of a relationship, and can be part of other problems like depression or anxiety, particularly with newer relationships. When we talk about relationship length, we often forget that some men and women who are a little older are in new relationships, and there's all kinds of anxiety that comes up when, maybe you're recently divorced or recently separated, or you have a new friend, and it's a whole new ball game because you were in this long-term relationship before where all of that has been worked out.
Mm-hmm. It really is a multifactorial process, isn't it? And you really have to look at the whole big picture. I know they talk about the whole biopsychosocial model, and it really holds true in this type of setting. In fact, I know that one of the things that people like to do when there is an issue with a couple is to actually have both members of the couple present for the evaluation. It can help a lot to kind of put it all in context.
Yeah, and one thing, even though we're talking mostly about women's sexual health on our discussion today, many times the problem with women's sexual health turns out that it's actually the male partner, particularly as they age or the couple ages together. He may be reluctant to initiate sex or even participate, not because their relationship is bad, but because he has some emerging erectile function problems and he doesn't want to fail, if you will, in that sexual engagement. So he withdraws. She thinks there's something wrong with her, or she thinks there's something wrong with their relationship. And what they really need to do is talk about it. And maybe he needs to see his practitioner, or if Dr. West is seeing men, also both of them together. And sometimes it takes them together in the same room with a practitioner just to get that out in the open.
Yeah.
But there are lots of reasons for low desire. I think the other thing I wanted to bring up is we now have medications that are FDA approved for low desire. Low desire, their approval, at least in the US, is for women who are premenopausal, that is to say, younger women before their menstrual cycles end. But in fact, one of those medications is approved in Canada for women up to age 60. So it works in older women. It's just not FDA approved for women past menopause here in the US.
Mm-hmm. Would you say that those medications are a very helpful tool for your patients?
So I think that they don't work in everyone. Now, it may be that they don't work in everyone because we, the practitioner, are imperfect in our diagnoses and what's really at issue, but they work in about 60% of women and about 60% of women regardless of their age. And so that's kind of what we're stuck with. We'll take the 60% solution and run with that. And if that doesn't work, go to a plan B. But sometimes just trying something means that both members of the couple are working toward the common goal, and that can be helpful in and of itself. One of those medications is called Addy or flibanserin, and it has a side benefit that is a couple of side benefits that are very pleasing to a lot of women. One is weight loss, and the other one is improved sleep. So if we're talking about women who are menopausal, losing a few pounds and sleeping and having a better sex drive, that can be the trifecta.
Sounds like a pretty good combination. I don't know too many women who would be unhappy with any of those things.
So if it only works for sex in about 60%, but you have a lot more energy because you're sleeping better, or you feel better about yourself because you've lost some weight and you like how you look in your own body, that can also be a boost to one's sexual interest. And, the whole thing works together.
While we're on that topic, we do have a question about whether you have any opinion about Vyleesi for HSDD.
Yeah, so Vyleesi is not the medication that we've just been talking about, which is, as I mentioned, Addy or flibanserin. Vyleesi is bremelanotide, which is a completely different medication, but works in the following way, and it's very interesting. So in the human brain and in a lot of animals' brains, the balance between desire for food and desire for sex is centered in the same place in the brain. And that's based on evolution. So if we can imagine all of us on this phone call living in a communal area in a cave where, 50,000 years ago, where we didn't have enough food, well, the women would be very, very thin, and their menstrual cycles would have stopped because they're too thin. And Mother Nature didn't want them having sex because procreation for baby making wouldn't be possible without reproductive hormones. On the other hand, if we're now in that same cave in a time of plenty, as we have now, we have plenty of calories available now, and there's enough body fat, then those women start to have menstrual cycles. And the brain goes from wanting to eat because we're hungry to wanting to have sex because we're hungry for sex. And in the brain, it's like on a playground. You have a teeter-totter of tilting from sex to food, to sex to food, etc. And Vyleesi works on that balance, tipping the scale to desire for sex. Vyleesi is used not every night the way Addie or flibanserin is. It's used as desired. When a woman's interested in sex or when her partner approaches her for sex, she gives herself a little teeny mini injection. And I know that sounds extreme, but it's actually a mini injection. And it stimulates within about 30 to 40 minutes interest in sexual interest and desire for sex, and also at the same time arousal, which would be vaginal moisture and tingling all at the same time. And it's, I think I have, I didn't plant this question, by the way. But I have this in my office so that I can show patients. This is the auto injector. Looks like this. And you just take the top off, and there's no needle, by the way, on this one. And just push it down, and it injects. And you put it not in your hand, in your abdomen. But the answer is it's got a very, very tiny needle in it. It's a single-use auto injector, and 30 to 40 minutes after its use, about 60% of those women are interested in sex as well. Like an EpiPen, yes. The question is it like an EpiPen? Yeah, actually the needle is smaller than an EpiPen. So it's really easy to do. We did the research on both of these medications, and the side effects of them, which are present in the label, turn out not to be a barrier for most women, including the concerns about being able to give themselves a shot.
That's great. And so it's just sound wonderful to have options, and what really amazes me is how few, even I think general physicians don't necessarily know about these options or don't know when the appropriate time is to offer them to people.
Yeah, I think that's a very important comment. I think we as a society have a long way to go still in understanding women's sexual health, in teaching our medical students, residents, fellows, other practitioners, nurses. We've got a long way to go. I think other societies and other cultures may have a little bit of a head start on us, where sex is more matter of fact and more just part of life. Here we're still a little puritanical and under the covers, so to speak, if the audience understands what I mean there. And we at Ishwish are working hard to get the word out. And sometime later this year, we'll be launching our first patient or average person facing website with peer-reviewed factual information that will be free. to any woman who needs really good information about women's sexual health.
I look forward to that. That will be great. Yeah. While we're on the subject of HSDD, let's talk just a minute about, for a little bit about the use of testosterone. That's come up in the questions, and I have a lot of people ask me about testosterone. It's been in and out of favor for quite some time now. So, and I understand there's some recent guideline, very recent publications about testosterone.
Yeah, so this is a very important subject.
Mm-hmm.
The first thing is that this is one of the areas in health where there's a tremendous disparity between women and men. So women need to know that they have lots of testosterone in their bodies all of their adult lives. In fact, women have 4 to 10 times as much testosterone in their body as they have estrogen. Now, that might seem like I've completely lost my mind, but in fact, that is a absolutely truism. One of the reasons that most practitioners don't know that is that we express testosterone in different units than we express estrogen. So the amount of estrogen in a woman's body is 10, 100, 1,000 sometimes, whereas the amount of testosterone is 10, 20, 30, 50. But the units, the numbers, are 100-fold bigger for testosterone than for estrogen. And so it seems like there's much less testosterone, but there's a lot of testosterone. We have about 30 different testosterone products for men and 0 testosterone products that are FDA approved for women. And that is a huge problem because we have women who have all this testosterone, which they lose as a matter of aging. And then they lose it if they have a surgical or induced menopause. And so we have to use men's products or compounded products to treat women who are missing or absent or low on their testosterone. That makes for a much more complicated treatment approach. The guidelines that Dr. West was mentioning were just published this past month after 2 years of working on this under my presidency at Ishwish, but they are now out and they talk about exactly how to use testosterone in women for low sexual desire.
So there's the potential that we'll be hearing more about the use of testosterone. We may be breaking down some of those barriers, it sounds like.
Right. And it's not complicated, but it does require some attention to detail. I like to tell my patients who are going to start on testosterone, we want to make sure you understand how to use testosterone because we don't want you looking like me. This is, I like to say, and I hope my wife believes, this is a good look on a man, but not such a good look on a woman. And too much testosterone will cause bearding and balding. And we don't want that.
So perhaps in the not too distant future, we'll have tests that can accurately measure testosterone in women at those lower doses, and we'll actually be able to adjust appropriately based on the existing testosterone numbers. My understanding is there's the current testing is kind of rife with problems, right? That's just why it hasn't been fully adopted by the medical community.
Right. That's one of the issues. One of the issues is that when you are using a testosterone test that was designed for men, it doesn't work very well when using it on blood from women. But there's a silver lining. All of the major laboratories, commercial laboratories, the LabCorps and the Quests of the world, they have a reference test that can be used equally well in women and men, but it's not so easy to get. And so it requires that the practitioner, Dr. West, for example, will have to do some digging and some coding changes, and patients may have to pay for it out of pocket or fight a little with their insurance company to get it. But it can be done. And let me just say how crazy it is. So most of the people on this call are from Northern Virginia or environs. And if Dr. West or I here in Washington, D.C. want to get this special testosterone test on you, we draw the blood and we send it, let's say, to Quest with these special codes on it. Well, it goes from my office in D.C. or Dr. West's office in suburban Virginia. It goes to Quest Laboratories, which happens to be in Chantilly, Virginia. But then they look at it and it has testosterone on it. So it goes to Baltimore, where there's another Quest laboratory. But then they look at it again and it says it needs to be done in the reference laboratory. So it goes all the way back to Chantilly where they'll do the test.
Oy.
I can't make that up. It's all true. Fortunately, the blood is very stable for testosterone, and women make lots of testosterone. And when done in the proper assay, in Chantilly, Virginia, by the way, for Quest, it comes out just fine. If it's LabCorp, it goes to San Juan Capistrano, California.
Oh my goodness.
But it can be done.
It can be done.
It can be done.
Do you want to take a minute and talk about some of the other ways that people are testing? I know I'm hearing a lot still about saliva tests, and I worry because it's hard for the average person to know the difference between some of these tests and to understand which ones are good tests and which ones really may not be helping them that much.
So Ishwish came out very strongly against saliva testing. And the reason for that strong recommendation against saliva testing is that it is not precise. Precise has a very specific meaning. It means if you do the test multiple times, it doesn't register the same thing each time. And that's a problem. So whereas if you took 100 women and measured their testosterone, you might be able to show a relationship to normal on the group of tests, 100 altogether, but it wouldn't tell us anything about what's the proper level or the current level in a particular patient. And while I might want to take care of 100 patients at one time to get them the best care that they can, we are forced to take care of people one at a time and individualize their care. And so salivary testing is just not going to be very useful in that setting. So no saliva testing, except for rare hormones, not pertinent to this discussion. For example, salivary cortisol testing is the reference standard when you're trying to find out what that particular test is for a given individual over a 24-hour period of time, but not for these reproductive hormones we're talking about.
Thank you. I think it's really important to get that word out because it just keeps coming back.
Well, there's a lot of money to be made in doing some of these fringe related tests. And I think that men and women who have problems are at the mercy of their practitioners sometimes. and we need to all be good consumers of care and be careful about these alternative approaches.
Terrific. There was a question just talking about testosterone research, and could testosterone research be beneficial for transgendered men? Or at least could there be some potential data sets available for those shared benefits?
Yeah, so this brings up a much bigger, more complicated question. The transgender community as a whole, whether they're transgender men or transgender women, have not been adequately studied in terms of the impact of hormones on them long term. We know what they do to change, how one looks, how one feels, body fat distribution, etc. But it's not at all clear what the long-term effects are in terms of, say, cardiovascular or heart benefits or risks, in terms of cognitive function benefits and risks. And ISWISH, for example, has lobbied to try and get more research funding for answering those questions, but we still have big holes in our knowledge base for cisgender men and cisgender women for those long-term risks and benefits. And some of those are actually studies that are ongoing, and we'll have to wait for the results of those before we venture further into the transgender community. But for those men and women, there are still some unanswered questions.
One other question just about, well, there are two more. One is about menopause and getting hormones tested. Is there any benefit to knowing how low hormones have gotten at any particular time? Or exact numbers useful around the time of menopause? Because we hear a lot of people talking about this.
So this is a bit controversial. I think most practitioners need not measure hormones around the menopause unless they're unclear where that patient is in the transition from being a reproductive woman to being a menopausal woman. Sometimes it's difficult to know and difficult to tell, and their blood testing can be very helpful in letting the practitioner know what's going on in that particular patient. I prefer, and I believe the guidelines focus mostly on symptomatology. So if a woman is menopausal and has hot flashes or night sweats or vaginal dryness or pain with sex, those are the symptoms. We treat the symptoms. We treat the symptoms with standard doses and standardized medication regimens. And therefore, testing is not really all that helpful. Now, if the treatments don't work at standard doses, then the testing becomes much more important. And I've had rare patients who are using standard doses of medications that aren't working because they're not absorbing them, or they're using them incorrectly, or they just aren't working. And so straightening out what's going on in a particular individual under those circumstances, well, the blood testing can be very helpful.
Mm-hmm. So you're thinking about like an FSH and an LH just in a person who's starting to go through the menopause transition isn't necessarily helpful. But if they're starting to have symptoms, then, and they're not sure whether it's that or a thyroid issue, then doing checking thyroid levels, maybe checking, let's say, for example, they've had a hysterectomy, but they still have their ovaries. Then that's where an FSH or an LH might come in handy. But then you would not necessarily do all the estrogen and testosterone and SHBG and all of those tests unless the symptoms are persistent.
Correct. Now, a woman who's had a hysterectomy, and by the way, about 25% of all women, some studies as many as 30% of all women have had a hysterectomy. If they had their hysterectomy before they went through menopause, then it's very difficult to know when their cycles stop because they have no bleeding anymore because they had a hysterectomy. And under those circumstances, it may be important to know what their hormone levels are and whether their FSH or LH are menopausal, because that marker of the end of menstruation is gone with their hysterectomy. And so just giving an added piece of information as to what's happening in their bodies might be the best answer to the question, but not as a routine. I think we can agree on routine blood testing for that may not be all that beneficial.
Let's do one more question on low sexual desire. There was a question asking if we could discuss that around the postpartum time and what's unique to that window of time.
So let's talk about that, but let's try and talk about it in a bigger context. Let's imagine that Mother Nature was really smart, because I think she is. She had 50,000 years to figure it out. I think I could have figured it out in 50,000 years, but Mother Nature did not want women who were postpartum, and let's imagine breastfeeding, to be having sex. Now you could say, oh, Dr. Simon, what, are you crazy? Come on. But let's think about it in the broader context. Mr. Caveman, remember, we're back in that cave, and Mrs. Caveman just had a baby and she's breastfeeding, okay? She has a decrease in her sexual desire because her hormones are very, very low, very similar to what we see in menopause, by the way. She may have vaginal dryness and pain with sex because her hormones are very, very low. She may be completely exhausted because that baby is crying because the baby wants to be fed every 2 hours, and Mother Nature said, oh, listen, she's going to be tired. She needs energy for the baby, not energy to have sex. So there are a number of situational and biological reasons that women who are postpartum are not interested in sex. Their focus is on the baby. Their focus is necessarily on taking care of the baby, not so much on their partner, okay? And while having some kind of sexual relationship that persists through the early phases of a new baby is very important, don't get me wrong. It's important to her. It's important to him. She may be tired. She may have hormones that are not conducive to sexual interest or sexual arousal. She may have pain with sex, real significant pain. Remember, she just had a baby through the birth canal. She may not want anything at all touching her down there at all. She may have bleeding. She may have tenderness. She may have stitches. Okay? It wasn't meant to be. And I will say parenthetically, Mother Nature did not want women getting pregnant too soon after their last baby because she wanted some child spacing. There's a lot of wear and tear on a woman's body in terms of getting pregnant, gestating that baby. And remember, we're living in a cave where there might be minimum resources in terms of calories and food. And we haven't really evolved out of that yet biologically, even though I understand we've got plenty of calories and plenty of food, and we have a much bigger problem with overweight and obesity, but the biology of sex hasn't quite evolved yet.
Let's switch gears a little bit from HSDD or low sexual desire and talk about some of the other problems that can come up for women. There are different categories of sexual dysfunction, and low desire is probably, one of the first ones that people think of. But let's talk about some of the options too. The other issues that might come up for people are things like medication issues that are caused by medications that people take, or other organic medical problems that may not either have been diagnosed or aren't managed well. Then there's also the category of problems with people who have trouble reaching orgasm. And then finally, another really big area, which is the pain that some women experience. So
these are really the gamut, if you will. So let's start with sexual pain, and then we'll jump over desire, because we kind of talked about that briefly, and get to arousal and orgasm and the medical issues that impede arousal and orgasm. So pain, sexual pain, is extremely common. When we talk about sexual issues being 4 out of 10 women, one of the single most common is sexual pain. And I like to divide sexual pain into 2 different broad categories. One would be penetrative pain. That's pain that's at the vaginal opening and is common right upon penetration. And that could be penetration with a finger, that could be penetration with a penis, but it's penetration. It could be penetration in a lesbian couple with a dildo or a strap-on or something like that. But it's penetration. The other kind of pain is more deep or pressure related, as if a woman's vagina somehow wasn't stretchy or somehow had been shortened. And sometimes we actually see this kind of deep pain, even though the woman's vagina hasn't been shortened or hasn't been reduced in its elasticity, simply as a result of menopause or aging, or because of something that's preventing it from stretching. And that could be some other disorder in the pelvis, nearby the top of the vagina, preventing the top from stretching during intercourse or some kind of penetration. That can be endometriosis, could be fibroid tumors, that could be scarring, that could be previous surgery, a whole bunch of things that can cause pain during sex. And it can also be from what we call tight pelvic muscles, pelvic floor muscles. So think about this in a bigger context. Humans, those of us on this call, we walk on 2 legs, as opposed to most animals that walk on 4 legs. And if you look at the pelvis, and I didn't bring a pelvis in, but if you look at the pelvis, the bones that hold our hips in place, it's completely empty at the bottom. There's no bones to keep our stomach, intestines, and all of our pelvic organs from falling out the bottom of our bones, except for a group of muscles. And that group of muscles are very, very sensitive. They have to let the urine out when we pee on demand, but keep it in when we're not in the bathroom. Has to let the gas out and the fecal material out on demand, separate one from the other, but keep them in when we're not in the bathroom. And in the case of a woman, has to let penetration happen while not letting out any of the other stuff. So these muscles have to be pretty sensitive to know what to do, when to do it. And if there's pain, they tend to clench up and tighten up. And when they tighten, they can cause constipation. They can cause urinary retention, and they can cause penetrative pain because they're tightened up. And sometimes women lose the ability to relax them as desired because they're constantly tightened up. And we see this very commonly in women who have pelvic pain from some other source, women who have chronic constipation, women who may have some level of incontinence where they're trying not to lose it. You know, the lawyer who's got to plead her case in court and is worried that she's going to lose her urine and, you know, end up with a puddle. That's not some situation that's easy to handle. And so she stays tightened up all the time. She may be nervous also. So those pelvic floor muscles are another cause of pain when they're really addressing one medical issue and they carry over to the issue of sexual pain. All of menopause causes the tissues in the vagina and the opening of the vagina to become thinner, more sensitive, less stretchy, and more likely to have pain associated. And some of those same changes can occur in much younger women who have been on birth control for a long period of time, who have been on other medications for a long period of time, etc. So there's all kinds of causes for pain. The good news is we have lots of treatments for pain. Almost always we can get rid of it. But we got to know about it to get rid of it. So that's the pain. We've talked about desire for sex. There are a lot of medications that we use very commonly in medicine, and unfortunately more commonly in women than in men, that interfere with desire for sex, arousal for sex, and orgasm. And the single biggest category of those medications are the antidepressants and the antihypertensives. So as we age, both men and women, we acquire medical problems. We just do. It's unavoidable. You get older, you get problems. And hypertension is one of them. And there are some medications that cause problems with desire, arousal, and orgasm in both men and women, and then antidepressants, which cause problems with desire, arousal, and orgasm in both men and women. So much so that we use antidepressants in men with premature ejaculation to slow them down. When they're used in women, sometimes we slow them down so much that they never get anywhere. And so this is a problem.
It can be a real challenge because you're balancing these things, and sometimes you can counterbalance one depression medicine by adding a different one. There are a couple of the antidepressants that actually seem to be helpful in this sphere. I'm thinking specifically of bupropion is probably the one that people know the best, or one of the brand names, Wellbutrin. Right. And it can actually help to counteract some of the problems that might come up.
Absolutely, totally agree. One of the problems with bupropion is that sometimes depression comes with anxiety, or anxiety comes with depression, and that particular agent is not all that great for anxiety. And so it's a delicate balancing act to try and overcome the sexual issues. The number one reason that women don't adhere to their antidepressants is sexual side effects.
such a challenge to find, what's going to work and what's going to be sustainable long term for people.
But that too, as you mentioned, Eileen, we do have some newer antidepressants that have fewer or even no sexual side effects. We sometimes can add an anti-anxiety agent to an antidepressant and get a little benefit for both the depression side, the anxiety side, without interfering with sexual function. So it's a little more challenging, but there are solutions.
Yeah. Yeah. Blood pressure medicines are challenging too. I think we see sexual side effects with several of the blood pressure medications, and I deal with this on a regular basis in my practice. We're switching and tweaking and tinkering and trying to get the right blood pressure management so that people are comfortable staying on their medication, but not having the problems that they really don't want to have.
Now, the last thing I want to bring into this discussion, at least on the aging sexual side effects, is that it may require that a couple change it up. So, just like men who commonly have erectile dysfunction as they age, 50% of men in their 50s have erectile dysfunction, 60% of men in their 60s have erectile dysfunction, 70% of men in their 70s have erectile dysfunction. In the same way, an increasing number of women in their 50s, 60s, and 70s have arousal and orgasmic difficulties. The drugs that we use in men do help women. It may not be so easy to get them to take them, but they do work for arousal, and they can help women with arousal and orgasm. But I want to bring up the fact that many women do not realize that while they used to be able to have orgasm relatively easier when they were younger, and a lucky minority of women could actually have orgasm during intercourse when they were younger, that an increasing percentage of women as they age, they need what I refer to as help. Those that in other circumstances, I've referred to them as power tools.
Mm-hmm.
So when I'm talking about, not to be absolutely direct about it, are sex toys, which means vibrators and other stimulating agents that can help women become more aroused and get to orgasm, as it may become more difficult. It may become more difficult simply because they're older. It may become more difficult because of medications that need to be used for their general health. It may become more difficult because their partners have more problems. Whatever the reason, it can be very helpful for couples to discuss it openly and to bring some toys to the party.
Do you have other thoughts about non-pharmacologic ways to help with desire or pain?
Yeah, so as it relates to pain, let's add dryness to the story of pain. Dryness is common for both men and women as they age. We have high percentages of women using moisturizers on their skin as they get older. It's an entire industry, the Olay group, as it were. But the answer is we all dry out as we age, and that includes women's vaginas. And there are moisturizers that are over the counter and that do not contain medication. They just moisturize, that women can use to bring moisture to their vaginas if they're having dryness or lack of lubrication as they become engaged in sexual activity. Separate from moisturizers, which are used in women's vaginas whether they're having sex or not. So Mrs. Smith has a husband that travels 28 days out of 31 days a month. She still uses her moisturizer 3.5 weeks out of 4, and she's better prepared for her husband when he's back in town. Moisturizers are different from lubricants. Lubricants are used at the time of sexual activity, and they are for her to put on him and for him to put on her and for her to put on her, and everybody gets lubed up because everybody's a little dry, and dryness leads to pain, and we want to take pain out of the equation. One of the little keys that I like to bring up in terms of lubricants, I like women to categorize their male partners, if they're in a heterosexual relationship, as being quick or slow as they age. No middle ground. They're either quick or slow. And the reason I like to qualify it that way is because there are some lubricants that are good for couples that engage in sexual activity that's relatively short in duration. And there are other lubricants that last a long time. And if you're engaged in sexual activity, you don't want to stop in the middle because the lubricant has now lost its lubricating qualities and it needs to be reapplied. So we need, in couples where it takes a longer time, a longer lasting lubricant. And so we want to take that as an issue out of the equation. So silicone-based lubricants last a much longer time. Water-based lubricants are much shorter, and they are sometimes in hybrid lubricants where there's a little of both, and they work both for the short and the long person. But like salad dressing that will settle out, like oil and water or vinegar and oil, the answer is hybrid lubricants. They need to be mixed also. So you can't, there's no free lunch there. So that's the first thing. And then if a woman is dry because her hormones are low, because of menopause or postpartum, or just she's having trouble with getting lubricated or becoming moist during sex, there's all kinds of medications, non-medications, over-the-counter moisturizers, over-the-counter lubricants that we can help with that issue of dryness or moisture. Lots of options, but you have to be able to use them. You have to be willing and get your partner to maybe apply them in the most sensual way. That's what's really important. And so we want to make sure that we get the word out on all of that.
Yeah. Lots to learn. Do you have any favorite websites or sources of information to people if they want to learn more about some of these products, or learn about, it's good to have something that's kind of neutral, to learn about these, or just on the topic in general? I mean,
So we have some information on our own website, that IntimMedicine.com, IntimMedicine.com. There's lots of educational information there. The North American Menopause Society has abundant information both for practitioners and for patients about sex and changes with menopause. For younger patients who may need instruction on how to do self-pleasuring or how to bring those conversations into a couple, I like a website called OMG Yes, like, oh my God, yes, OMG Yes, which is going to sound a little gross to the audience, but it is a website that teaches women how to masturbate and how to self-pleasure. And it's the first step in teaching one's partner how to help, is to know how to do it yourself. And you would be amazed how many women don't know how to. And this is a good way to learn about oneself, learn about what one likes, and then learn how to teach your partner. And that's a good place to start. Those are kind of my favorite go-to websites.
Yeah, yeah, that's terrific. And I have recently taken a look at some of these and explored some of these, and these are fantastic websites. I mean, they're very factually based. They're very straightforward. They take some of the embarrassment out of the whole process. It's information. It's what it's the things that you need to know how to work your body the best way you can. So
the other thing I would say is that when a woman has a sexual problem, regardless of what it is, and regardless how easy or how difficult it is to take care of, it frequently sets up a new paradigm in their relationship. And sometimes that new paradigm needs to be attended to in order for them to re-engage. Let's take a simple thing like menopausal pain or erectile dysfunction, or a combination in an aging couple who are very much still in love and have a good relationship, but now there's a new barrier. Does she approach him for sex when he used to initiate because now he's shying away from her because he has erectile problems? Or he's shying away from her because she has pain and she doesn't really want to engage, or any combination of those things? Well, now we have to take care of the problem, whether it's ED or sexual pain or dryness. But now they have this shying away in their relationship that needs to be addressed. And sometimes that requires getting them into the office together, having a good talk about it with some moderator. That's your job, Dr. West, or my job to be the moderator, to just get them talking. And then starting slow as if they were, teenage kids again, even though they're 70-year-old couple that's been together for 30 years, but now they've been on hiatus for a while. And now we need to reestablish that intimacy, communication, and sometimes that takes a medical professional to overcome the psychological divide that whatever this problem has created.
And there's a wonderful group of people out there who are sex therapists. They're psychologists and social workers who have learned and trained and have really mastered this process of helping people with this particular topic. And that's an invaluable part of a team if you're going to be looking at trying to manage this problem from several different angles. And I'll just throw a shout out for the other group too that I just think is absolutely incredible. And I really never fully appreciated what they do, but that's the group of pelvic floor physical therapists. There's the whole arena of pelvic floor physical therapy, which is a much needed and much overlooked area. And it's really amazing what these pelvic floor physical therapists can do for pelvic pain and other, sexual health related issues for both women and men. It's really remarkable. And we're very fortunate to live in a part of the world where we have quite a few really good pelvic floor physical therapists in the area. So, and we're working on bringing one into our practice, which I'm really excited to see see happen.
I could not agree more. I think our practice down here in DC probably keeps the pelvic floor physical therapists in the whole area pretty busy overall. and it's an important part. When I spoke about those muscles and how tight they can also be too loose. That's at least the target of the physical therapist, to help them to become of normal tension. Got to keep all your stuff in, but let it out on demand, so to speak. Those all need to be taken care of, and we do have good psychological and psychiatric care available to us in this area. I actually trained as a sex therapist before I became a physician, as is news to Dr. West. I know, I saw it on her face.
Yeah, I know that.
I did my training, if you can imagine, with the World Authority on Sexual Function in Children of Incest. So these are adult men and women who were abused as children by a member of their families, and this creates all kinds of counseling issues and problems related with trust, and that's where I did my training. Although I don't do couples therapy anymore, I certainly have a really good insight and appreciation for good sex therapists.
That's great. I think the bottom line is, if you as a patient are experiencing any of these types of issues, just know that there's help available. There are lots of people out there who are ready and willing to help you work through some of the issues that you might be having. So don't give up.
Definitely don't give up.
Yeah.
Definitely do not give up.
Yeah.
And if you're a practitioner, and this is not about myself or Dr. West, but if your practitioner who you're seeing doesn't know about these issues, or seems to be bewildered by what to do next, just ask them to refer you to someone who knows. There are lots of people in this area with special expertise and specialized training. And I think that going on the NAMS website, going on the ISHWISH website, we have practitioner lists who have specialized training, specialized expertise. No one should be suffering in silence. Let's get it out there and get people some help.
Indeed. Well, thank you so much, Dr. Simon, for coming on and bringing these questions and answers to us. I really hope that the audience has enjoyed it and has had an opportunity to learn from it. Just know that we are out here and we are ready to help in any way that we can. I'm in a concierge internal medicine practice in Fairfax, and we focus on women's health. We work with some of the wonderful resources that a national organization called IntimMedicine has to offer. And it's really a great opportunity to explore some of these issues in more depth. And Dr. Simon, as the surgeon and the researcher, can also help so much with very specific sexual health related physical problems. And his whole team can be a valuable service for people who need that. So
thank you.
So I really enjoyed this. Thank you so much for taking the time with us, Jim. And I really hope we can do this again soon.
Well, they're shutting the lights off in my place. It was really my pleasure. I hope the audience enjoyed it, and love to do it again soon.
Wonderful. We'll do it for sure. All right. Thank you so much.
My pleasure.
And thank you all for tuning in, and we'll see you next time. All right.
Bye now.
Bye now.